Today I'm talking about some of sort of the new up-and-coming CPR research that's out there. I'd like to thank Mike Llewell for helping me, and he's my supervisor today, and then also to Shelley, who sat down with me and went over some of these papers. So to start with a quote, this is from 1960 when CPR was first described. "Anyone, anywhere can now initiate cardiac resuscitative procedures. All that is needed is 2 hands." And I think in some ways we've come full circle back to this. So, bystander CPR, really now, 2 hands, you're good to go. CPR still looks a lot like this. This is how it looks in our emergency department, some combination of chest compressions, defibrillation, plus or minus a face mask or an endotracheal tube. But CPR also looks something like this. Just a couple weeks ago, actually, I was working with Crispin, and we had someone roll in who had been on AutoPulse because Oxford happened to be in town when they picked up an arrest. And a lot of people in the department were sort of like, what is this thing, and what's going on? And, this is a strange new CPR, which not necessarily, but we'll talk about it more today. And then maybe this will be CPR of the future. So this is a compression-decompression CPR with an impedance threshold device, and we'll talk more about that. So objectives for today, to review some of the challenges to providing high-quality manual CPR, go over some of the literature supporting and refuting mechanical CPR, talk about some of the physiologic limitations of even the best manual and mechanical CPR, and then review some of the recent literature on the ITD with and without active compression-decompression CPR. In terms of providing high-quality manual CPR, which I'll refer to as MCPR for the slides, we know that quality of chest compressions is associated with survival, and the AHA really emphasizes continuity, rate, and depth of compressions, and maximizing hands-on time. This is something many of us are used to talking about at ACLS. We know continuity to be important. Pauses in chest compressions are associated with decreased short-term survival. And we know that from animal studies, pauses as short as 4 seconds actually decrease cerebral perfusion pressure. Continuous CPR, though, is really hard to provide. It's hard to provide in the pre-hospital setting especially, and has been described as paused up to 48% of the time, which you can imagine the logistics of that, moving from wherever the person has arrested downstairs into the ambulance, the busy ambulance ride, getting onto the stretcher, lots of opportunity for pause. Just this year, actually, Sheldon Cheskes out of Toronto published this paper, Perishock Pause, looking at perishock pause as an independent predictor of survival from out-of-hospital cardiac arrest. So what they did in this series is they reviewed 815 cases of VFVT that had available ECG and impedance data from a ROC data set. And they looked at survival as a function of the time between when CPR stopped and defibrillation, that's the pre-shock pause, the time between when CPR stopped and picked back up, that's the peri-shock pause, and the time from defibrillation to CPR resumption, so that's the post-shock pause. So this is sort of what it looked like that they were looking at. So you can see this is your ECG data, this is with the CPR effect, and then this is just the raw ECG data when CPR is being stopped. And then they have this impedance data. So this is when you have chest compressions, and then there's this pause. And this is the time where either the machine or the rescuer is doing interpretation of the rhythm. And then there's the shock, and then you have a brief post-shock pause, and CPR is resumed. They looked at this a few different ways. I think the easiest way to think about it is that they modeled it continuously, and they found that the odds of survival were 18% lower for every 5-second increase in the pre-shock pause, beyond sort of their minimal pre-shock pause. And the odds of survival were about 15% lower for every 5-second increase in the peri-shock pause. The odds for the post-shock pause were found to not be significant. But so for every extra 5 seconds that CPR is not going on in VFVT, you have a decrease in survival. Potential means of decreasing pauses. Automated versus manual rhythm interpretation, which I'll talk about a bit in the next slide. And then we'll talk about ultrasound briefly, and then mechanical CPR, of course. So here you can see at the top there's a hatched line. That's the pre-shock pause using an automated defibrillator. Below it there's a solid line. That's the pre-shock pause using a manual defibrillator. below that are post-shock pauses for automated and manual defibrillators. So there's no question that the automated defibrillator takes longer to interpret the rhythm and deliver a shock than manual defibrillation. This is a topic of controversy, certainly in pre-hospital settings, because currently BLS providers often use automated defibrillators, which leads to longer perishock pauses, but potentially also leads to shocking the right rhythm more of the time. So something that has the potential to be practice changing in certain settings. And I think potentially is changing practice already in Toronto, where some of this study took place. Rob Arnfield wanted me to briefly mention the use of ultrasound for decreasing perishock pauses or decreasing pauses, which I think is really relevant for us in the emergency department. You know, oftentimes in a PEA arrest, we're trying to get the ultrasound on and have a look, is there a reversible cause here? And it takes a long time to get the ultrasound on and to kind of get the right image and then to make sense of the image. CPR is paused oftentimes for 30 seconds, a minute. If you go on to then resume CPR, this is potentially having a detrimental effect for survival. So something we may see coming down the pipeline is the use of transesophageal echocardiography, where you avoid all those problems because the probe is now inside the patient. You can continue along with your CPR, do your pause, have a quick look while you're doing your rhythm analysis. You get more information about the rhythm and the heart rate and all those things. And maybe we'll see more of this coming. Certainly could help decrease pauses. In terms of further challenges, we know rescuer fatigue plays a huge role in providing high quality CPR. In a study looking at chest compressions being given to a mannequin, 92% of the time they were given properly in the first minute, the right rate, the right depth. Drops to 67% in the second minute, 39% in the third minute, and only 18% by the fifth minute. So something to think about if we're running arrests and ego kind of gets in the way and the PSWs are like the strongest, and after 2 minutes they should be switching, period. And there's good evidence that even if they're just providing CPR to a mannequin, the quality is decreasing quickly. Further challenge in the pre-hospital setting is, giving manual CPR in a moving ambulance, it's hard to do and it's unsafe. Ambulance vehicle crashes are the most likely cause of work-related fatalities in EMS. We know that ambulances have fatality rates per mile that are higher than trucks and passenger vehicles. They're one of the most dangerous vehicles on the road in terms of fatality rates. And most accidents, injury, and fatalities occur during lights and sirens transport, which is how these codes are coming. We know that most serious and fatal injuries occur in the back of the ambulance, which is where people, of course, are providing CPR. And by and large, with ambulance design the way it stands, CPR means the paramedics are not restrained. In at least one study, unrestrained individuals have a disproportionate contribution to mortality when involved in crashes. So 52% of fatalities were unrestrained rear occupants, despite the fact that only 12% of the population they looked at were unrestrained rear occupants. CPR makes this even harder because the medics don't have free hands to aid in balance. So it compromises paramedic safety, and it also compromises CPR quality. Hard to give good quality CPR when people are grabbing onto things to stay balanced in the back of the truck. And this leads us back to mechanical CPR devices. So this is the AutoPulse load distributing band. It's made by Zoll, and it's the one that's used in sort of our area, so it's the one I'll focus on, and also one that has the most recent research. I don't know if the sound will play on this, but it's a quick video that I swiped from YouTube, just demonstrating what the AutoPulse looks like in action, if any of you guys haven't seen it. Hopefully it will play.
Ventilations with them. Then we get the AutoPulse on them, and two of us working together can do this in about 30 seconds. But we line them up with the board. There's a yellow marking that we line them up with. We put this life band up on them, and we extend it fully and put it back down. The board goes on. We could have put the board on earlier. It checks itself out. It gives me a message, align the patient, which I've done, and press continue. I press continue. It measures up the patient automatically. If I don't do anything, now it starts to compress. And it'll do that. Now, right now it's set for 30 to 2. So it'll do 30 compressions, tell me I need to ventilate. So in a couple of seconds, you'll hear 3 beeps. Those beeps are telling me get ready to ventilate the patient. Ventilate, ventilate, CPR. Manual CPR is only good for the first couple of minutes.
So hopefully there aren't too many inaccuracies to the way they're using the device in that video, but just to kind of give you guys an idea what it looks like. And you can change the settings, so it doesn't have to be set at 30 to 2. It can be set to work continuously if you have an airway established as well. So the device was approved in the States in 2001 and approved by Health Canada in 2003. And some of you it might sound vaguely familiar because Samir has actually done most of his research surrounding the use of AutoPulse in Oxford County here in southwestern Ontario. It has huge logistic benefits, paramedic safety, avoids rescuer fatigue, and it provides consistent, uninterrupted chest compressions. The battery is supposed to last about half an hour, so that'll get you pretty far in transport. However, the efficacy of the device in improving patient outcomes remains unclear. So in June of 2006, JAMA published 2 large papers reviewing the automated load distributing band CPR using AutoPulse. The first was ASPIRE, which is manual chest compression versus use of an LDB during resuscitation following out-of-hospital cardiac arrest, a randomized trial. So nicely designed, randomized trial. However, it was stopped at the first planned interim analysis by the Data Safety Monitoring Board. They found at that point there was no difference in the primary outcome of survival to 4 hours. However, survival to hospital discharge was markedly higher in the manual CPR group than it was in the group that received AutoPulse. So they quickly terminated the study, and that was it. However, they had multiple limitations. They didn't measure time to first CPR. However, they did measure time to first defibrillation. And they found that the time to first defibrillation in the AutoPulse group was significantly longer than in the manual CPR group. At Site C, there were multiple sites which had the highest historical survival, 31% historical survival from VFVT. They actually had the worst outcomes with AutoPulse. However, this was the only place where they did CPR process measurements continuously at that time, and they realized that CPR was taking longer to be initiated with use of the AutoPulse device, such that actually at Site C, they changed their protocol a little bit. The manufacturers had left it quite open, and so most sites were just not doing any compressions, getting AutoPulse on and then going. And shortly before the study was terminated, they actually changed their protocol at Site C so that they started with manual CPR, then got the AutoPulse on when they could. There was also potential for enrollment bias that the authors questioned at least. Were paramedics maybe putting AutoPulse on a patient who otherwise would not have been resuscitated? Maybe not looking as hard as, for the DNR form, not sure. So that was ASPIRE, ended quickly. In the same issue of JAMA, there was another paper that was a phased observational cohort study published. This was by Ong et al. And so they did, it was 783 patients. 500 were included in the manual CPR phase, and then 284 in the AutoPulse phase. And in this study, all of the patients had initial manual CPR while the AutoPulse was being set up. Primary outcome was ROSC, and they found a significant increase in ROSC using AutoPulse compared to manual CPR. While it was not a primary outcome, they actually found improved survival to admission and hospital discharge using AutoPulse. So 2006, same issue of JAMA, AutoPulse is the studies ended early in one set because of potential harm, and then there's this same other study that shows potential benefit. So Cochrane in 2011 says, insufficient evidence to conclude that mechanical chest compressions is associated with benefit or harm. And the 2010 AHA guidelines say 1 multi-center prospective RCT demonstrated no improvement in 4-hour survival and worse neurologic outcome. These results raise concern about possible harm. The low distributing band may be considered for use by properly trained personnel in specific settings for the treatment of cardiac arrest. There is insufficient evidence to support the routine use of the low distributing band in cardiac arrest. And so this brings us into 2012 and the CIRQUE trial. So this trial was, the methodology was published last year in Resuscitation, and the results were presented at NAMES-P this January, and have not yet been accepted for peer review publication that I'm aware of. And so they looked at adult patients, non-traumatic out-of-hospital cardiac arrest of presumed cardiac origin, and resuscitation was attempted. Exclusion criteria fairly straightforward, including if they were too big for AutoPulse, which would be fairly large, if they'd previously had a different mechanical chest compression device applied, if the EMS unit got there 16 minutes after the EMS call, which I think probably speaks to futility, and then the exclusion criteria were mostly applied post-enrollment. So the intervention group was randomized to receive AutoPulse CPR after initiation of manual CPR, and the comparison group received high-quality manual CPR. Primary outcomes, survival to hospital discharge. Secondary outcomes, ROSC, 24-hour survival, and neurologic status at discharge. The authors described 6 unique features, which are arguably unique, but they're interesting. They had significant training to decrease hands-off time, both in the initial manual CPR phase and then also in the manual CPR group. They had a pretrial simulation phase, 3 distinct study phases, so there were multiple phases before the data was collected and used in analysis, and you could move between study phases if you weren't meeting criteria for high-quality CPR. Continuous monitoring of the CPR process. Patients were randomized after the decision to resuscitate was made, and then they used this group sequential double triangle test. And essentially what this is they set predefined stopping boundaries, so a stopping boundary for superiority, inferiority, or equivalence. And then the data is analyzed almost continuously by the folks that do that, the sort of Shelleys of this study. and then once they reach a stopping boundary, regardless of which one it is, which is predefined, they stop. And the benefit of this is it allows a smaller sample size than is traditionally used the way we do studies to hopefully come to a conclusion, particularly if you reach your equivalence stopping point. You know, it's not something we're as familiar with in terms of methodology, and I spoke with Shelley a bit about it, and she thought it seemed, you know, not unreasonable, but it's certainly different, and she's curious to see how this does with peer review. So what the paramedics do, they bring AutoPulse to every call, and once cardiac arrest is confirmed, one rescuer starts manual CPR, the second person cuts off the clothing, gets the defib on, and then opens the randomization card on AutoPulse. Manual CPR is then either continued or AutoPulse is applied. And the results as presented at NAMES-P, they had over 4,000 eligible patients. In total, about 2,000 in each group for automated and manual CPR. And pretty good follow-up, discharge status unknown for only 12 cases. And after adjusting, they found equivalence between the AutoPulse CPR and manual CPR. And the adjusted odds ratio fell fully within their predefined equivalence region. And they found no significant difference in discharge with neurologically intact discharge with a modified Rankin scale of less than or equal to 3. So what does that mean? You know, if truly these devices are equivalent, I think we can expect to see more marketing of this as an EMS safety device, and you know, potentially see more of it in settings where CPR is traditionally of lower quality because of fewer rescuers, longer transport times, that sort of thing. You know, whether this is ever going to be prime time in resus-evic, unlikely, but we may see more paramedics coming in or using this sort of device if Zoll is able to successfully market it that way. So switching gears a little bit now, I'm going to talk about, you know, where even high-quality mechanical and manual CPR fall short. We know that the primary goal of CPR really now is not cardiopulmonary resuscitation, but cardiocerebral resuscitation. At the end of the day, what we care about is neurologically intact survival. Routine CPR really doesn't provide a very high fraction of normal cardiac output. And largely that's because provided breaths and passive inspiration cause an increase in intrathoracic pressure, which decreases preload and decreases cardiac output. In animal studies and small human studies, preservation of negative intrathoracic pressure has been demonstrated to increase preload, then improving cardiac output and cerebral blood flow. So there are a few different devices designed to accomplish this, and that's what we're going to talk about now. So the first one is a trial of impedance threshold device in out-of-hospital cardiac arrest. This study was actually combined with Ian Steele's early versus late rhythm analysis, so patients were enrolled in both this study and the early versus late study. And it has very similar conclusions, so easy to remember that way. And basically the background is this ITD increases the degree of negative intrathoracic pressure by preventing passive air inflow during chest recoil, enhancing venous return and improving cardiac output. And in animal models, it improves perfusion to vital organs and has been shown to improve short-term survival. So the investigators' question was, does application of an impedance threshold device during CPR improve rates of hospital discharge with satisfactory neurologic outcomes? And this is the thing, this is the ITD. I don't know if any of you remember seeing these. Our site actually participated in this ROC study. No? So this is what it looks like. There's some timing assist lights, a little pressure sensor system, and you throw it out after you use it. And the idea is that you can give breaths, but when you're not actually giving a breath to the patient, air isn't coming in passively, but can go out. It can be attached either to a face mask or to an endotracheal tube. And that's how the device looks and works, essentially. It's not very complicated. So population for this study, adults with non-traumatic out-of-hospital arrest, very similar exclusion criteria to most of these studies, with the exception of existing tracheostomy, which presumably might impact the way that the device functions. So the intervention group got the active ITD, and providers attached the device between the bag and mask, and then when they insert the advanced airway, they would attach it. Some of these patients also had it attached to like a combi tube or an LMA that was allowed as well. They were encouraged to apply the device within 5 minutes and instructed to remove it if there was return of spontaneous circulation, and then put it back on if there was rearrest. A nice design in that the comparison was an identical sham ITD. Looked just like the other one, except it didn't have any prevention of air inflow. Primary outcome, as I mentioned, survival to hospital discharge neurologically intact, and standard secondary outcomes. And they also captured adverse events possibly related to device use. So failure to remove the device at ROSC, they counted as an adverse event. Device failure, pulmonary edema, and airway bleeding. Those were the big ones. So they randomized it 1-to-1. It was concealed, and the providers were told to use the device in an assigned sequential order. They were considered enrolled once the package was opened, regardless of if the device ever went on the patient. And the patient's treatment team and coordinators were all blinded. In total, 9,000 patients were assigned to either the sham ITD or active ITD groups, about 4,600 in each group. And then they applied the a priori exclusion criteria to end up with about 4,300 in each of the groups for analysis. And in total, 6% of the sham ITD and 5.8% of the active ITD reached the primary outcome. And the study was terminated early because they suggested the continuation of the study was unlikely to change the findings. And again, very similar to the early versus late study. They stopped early because of futility. Or sorry, I shouldn't say futility, because there was no difference. So potential explanations for that, it looked really good in animal studies. Maybe the device doesn't generate the proposed physiologic effect. Like the device is no good. Maybe the device generates the proposed effect, but not when applied in that manner. They had late application in many cases. Oftentimes it was not applied until 5 or more minutes into the resuscitation. Maybe because of air leaks with the bag valve mask, particularly early. Maybe because the CPR was of low quality. Or maybe the device generates the effect, but the effect does not improve clinical outcomes. So going back to the first point, why the device may not generate the proposed physiologic effect. We know that during CPR, chest recoil is lost over time. Loss of chest recoil means that negative intrathoracic pressure is no longer being generated. And this was the rationale for the rescue trial. So what does the AHA say about the ITD? This is, of course, before publication of this most recent study. The use of the ITD may be considered by trained personnel as a CPR adjunct in adult cardiac arrest. And so at that time, they said, you can use it if you want to, sort of thing. And I would I'll be surprised to see if it's still regarded as favorably in the next AHA guidelines. So briefly, I'll just talk about compression, decompression, CPR as background for rescue. So most of these studies were done in the 90s initially, and then summarized in a recent Cochrane review. So in this Cochrane review, they did a meta-analysis of 8 studies in out-of-hospital cardiac arrest, over 4,000 patients, and they found no difference between compression, decompression CPR, and manual CPR for mortality immediately or at hospital discharge. In the meta-analysis, there was a trend towards increased neurologic impairment of any severity using compression, decompression CPR. So AHA 2010 said insufficient evidence to recommend for or against use of compression, decompression CPR may be considered for use when providers are adequately trained and monitored. Which takes us to the rescue trial. So they looked at standard CPR versus active compression, decompression CPR with augmentation of negative intrathoracic pressure for out-of-hospital cardiac arrest. And the question then is, is compression, decompression with an ITD superior to standard CPR in achieving neurologically intact survival? And this is this setup. So this is the compression, decompression device. This particular one is called the rescue pump. That's the ITD there attached to an endotracheal tube. And the compression, decompression device also has a pressure gauge on it. So on the next slide, there's just a quick video showing what it looks like. You can see the pressure gauge actually informing the rescuer how hard they're pushing down or pulling up.
That got this scientific mind thinking. Maybe there is a simpler solution to improving CPR,
Essentially,
and it sparked
it's a plunger,
the design of the rescue
right?
pump.
Very expensive plunger.
Yeah, that's the thing. It's hard to sort out why this should be such an expensive plunger. You would think it could maybe be made for very little money. So what these guys looked at is adult cardiac arrest patients, 7 different sites, 46 EMS agencies participated. They had a mixture of urban and rural settings. Their exclusion criteria initially were excluded if there was a traumatic cause of arrest, they had a DNR, they were obviously dead. They excluded in-hospital arrests and also excluded patients who'd had a recent sternotomy, I think for fairly obvious reasons. The final exclusion criteria were if the patients in the end only had less than a minute of CPR, if they had a complete airway obstruction, if they were intubated with a leaky or uncuffed endotracheal tube, if they had an existing tracheostomy, or if it was deemed to be a non-cardiac cause of arrest. So in terms of the compression, decompression in the intervention group, it's a suction cup attached to the chest with a handle, a metronome, and a force gauge. And the operator just pushes as hard as normal CPR and then pulls up. Metronome was set to 80 beats a minute, and the force gauge tells you, push harder or pull back harder. That's the rescue pump again. And then the ITD is set with an inspiratory impedance of 16, expiratory impedance of less than 5. And as we talked about, lowers intrathoracic pressure during decompression by impeding passive inspiratory gas exchange, allowing positive pressure ventilation. And like the other ITD study, it was initially attached to the face mask and then attached to the endotracheal tube if inserted, removed if ROSC, reapplied if rearrest. They stopped the study intervention once they got to the hospital and replaced it with traditional CPR. And therapeutic hypothermia and cardiac catheterization for revascularization were encouraged by the study investigators. I think about 40% of patients or so received therapeutic hypothermia in each group. So while encouraged, it wasn't uniformly applied by any means. In terms of the comparison group, they received standard CPR. They had training every 6 months minimum during the study, and they emphasized hands-on time, switching every 2 minutes, and really tried to encourage the providers to be doing high-quality CPR when they weren't doing the intervention. Primary outcome, again, neurologically intact survival. And they looked at secondary safety endpoints, which were major adverse events, so death, rearrest, cerebral bleeding, seizures, pulmonary edema, bleeding requiring transfusion or surgery, chest fractures, thoracic or abdominal injuries, and then device malfunction or defects. It was a prospective study, computer-generated block randomization in blocks of 4 weeks, assigned in a 1-to-1 ratio. And obviously here the paramedics were not blinded, and the resuscitation team probably was not blinded as well. You know, maybe a few people, if they walked in late and they'd got the ITD and the plunger off the chest, they may not have known, and they encouraged the paramedics not to disclose which group the patients had been in, but oftentimes the care team knew. The people assessing neurologic function, though, were blinded. Study nurses were blinded, and people doing chart reviews were supposed to be blinded to which intervention the patients received. And the manufacturer, who played a fairly significant role in the study, was blinded as well, except in cases of device failure. So initially, they calculated their sample size, assuming 6% survival to hospital discharge in the control group and 10% in the intervention group. They had a planned midpoint analysis at 50%, and at that point, they increased their sample size because they realized the difference was less than expected. But then they ran out of money at 1,600 patients. So they finished up with very close to their initial sample size calculation. They initially had a third group which would receive ITD alone without compression-decompression CPR. And what they say in the paper is that they stopped this group at 150 patients given slow enrollment. There's the other part of this, which is that it's the same first author on this paper and on the ROC paper, which is looking at ITD alone. So I'm sure there was some interaction there as well. In terms of the results, again, 1,600 patients. And I think if there's one take-home message for the talk, this is pretty interesting. The intervention led to a 53% increase in survival to hospital discharge with a modified Rankin score of 3 or less. Odds ratio of 1.58, just about 1.6. Very few things that have been done in resuscitation in the last few decades have shown an improvement in survival to neurologically intact discharge. You know, CPR, defibrillation, therapeutic hypothermia. I don't know if anyone else can think of anything, but you know, none of the drugs that we give in cardiac arrest have demonstrated improved survival to hospital discharge neurologically intact. So if you believe this study, it's kind of a big deal. Not much has happened in resuscitation that potentially could be as impactful as this in terms of improving survival to hospital discharge. When they break it down by subgroups, you know, all patients, you see a survival benefit here. And then old patients, young patients, still falls on the right side. Women, men, different rhythms, VFVT, witnessed, unwitnessed, early CPR, late CPR. And then you look down, one of the sites fell at 0.99, so essentially equivalent, benefited all the other sites, which traditionally probably had variable qualities of manual CPR. So, you know, it looks pretty good. They found no significant difference in total adverse events between the two groups. However, they did find that pulmonary edema was 50% more common in the intervention group. I think this potentially speaks to the fact that the device had the expected physiologic effect, causing a significant amount of negative pressure, negative intrathoracic pressure. And the authors kind of say, well, 50% more pulmonary edema, 50% more survival, you know, that's okay, but something to think about that it was more common. In terms of limitations of the study, of course, they're unable to discern the relative contribution of the ITD, of the compression-decompression CPR, and of the timing assist features. So maybe all you need is a metronome and someone yelling, you know, when to give compressions and when to give breaths, and you know, potentially that could be as good. It's probably cheaper than all these devices. Hard to know from this study. And then, of course, the device manufacturers were heavily involved, which is a major limitation of most of these studies because the devices aren't cheap, and the device manufacturers almost always end up having some role, at least in the initial phases. So in conclusion, providing high-quality manual CPR is hard. It's hard in the field, it's hard in the emergency department, and we don't do it as well as we could most of the time. AutoPulse, if you know, CIRQUE pans out and is accepted for peer review publication and becomes accepted truth, it's probably equivalent to high quality CPR in the pre-hospital setting. Certainly has logistical advantages. We may see more of it in the future. Cardiac output and cerebral blood flow during manual CPR are limited by high intrathoracic pressure, low venous return, which causes low cardiac output. And in one large randomized control trial just published this past year, compression decompression CPR with an ITD improved neurologically intact survival to hospital discharge by about 50%. So that's all I have. There's lots of time for questions if you guys have any.
One of the big questions we're facing from the EMS services in regards to this Sheldon Cheskis data you presented about CPR fraction is, should their PCP paramedics be doing manual defibrillation? Because a semi-automatic mode takes up as much as 45 seconds, not always, but as much as 45 seconds to analyze the rhythm. Anecdotally in the department, I think we probably take way too long to analyze the rhythm. We should be trying to do it in less than 5 seconds, and that's actually the numbers that the newer ROC trials require the paramedics to do it in. They have to, 75% of the time, analyze the rhythm and make a decision within 5 seconds of looking at it. So that's something as clinicians we should have a goal to do as well, I think. But we're sort of, the services, or the EMS services, are wanting to move to manual defibrillation by primary care paramedics. And it's a risk benefit for all the decisions they need to make in that short time frame with limited sort of call volume for a lot of the paramedics. So what we're currently, Mike and I and the other medical director-based hospital are pushing them to do is focus on other ways of increasing CPR fraction as opposed to switching right to manual defibrillation as a new skill set for those paramedics. That's basically been the clinical outcome of that trial.
Adam, how far are we or services around here away from the new technology which allows see-through CPR analysis of the...
That technology actually isn't out there yet. So Oxford County has introduced, with their AutoPulse, they've introduced shock sync technology, which means that the defibrillator will shock while the AutoPulse is providing CPR on the upstroke of CPR, because the success of converting a rhythm or defibrillating rhythm is higher if you do that. But that device currently requires manual rhythm interpretation. So the only primary care service in our area that's gone to manual rhythm interpretation is Oxford County, so that they can use this shock sync technology, but not see-through technology. So what John's saying, see-through technology would mean while the machine is doing compressions, the machine can also analyze the rhythm without stopping compressions ever. But the current technology that's actually approved for use in humans is you stop the CPR machine, you look at the rhythm, you make a shock decision, you press shock, and the machine or the AutoPulse starts doing compressions again and chooses when to deliver the shock. So we, through a fairly long education program, Oxford County PCPs are now doing manual rhythm interpretation in order to use that device.
We lag behind in our own teaching with CPR. I mean, and I'm old enough now, I've been around enough now to see like the emphasis on CPR has changed substantially from like we used to, you could randomize people just to watchful waiting in the circle of concern to actually like full-on compressions, no compressions or enough compressions. And this paradigm has been that's like 10 years, this massive sort of shift. And it's amazing to me how we don't even follow our own literature. Like in the department when we're running an arrest, there's good literature out there showing that you can actually, with vinyl gloves on a chest, actually continue compressions during a defibrillation and not even notice the defibrillation. But yet we almost all run into the room before the Zoll shocks someone, and we all stare at it afterwards. And yet, really, our decision to treat should be lift your hands, look at the rhythm, decisions made to shock, back on the chest, and we're gonna, when it's ready to shock, we're gonna shock, and potentially we could actually keep doing compressions while the machine shocks. I echo there's been students, it was actually medical students that were randomized to doing it with vinyl gloves. And I echo Adam's concerns that about this shock sync technology, but I think that we're going to get to a point where we have total assimilation, where literally you're going to run into a room, you're going to apply an automated device like an AutoPulse, and then you're going to use the read-through CPR machine, which will basically read the rhythm the entire time, find out when the wave is perfectly coarse, and then figure out the relaxation phase of the heart and actually deliver defibrillations, which then takes the need for any scene time. The paramedics will run in, apply the machines, lift him out, arrive in the department and say it went off 4 times. And it may be when, it may not be every 3 minutes or 2 minutes, it may just be when the wave was right and the decompression was right. And we're not far from that. And I think that I'm always astonished, and I'll get off my soapbox in one last second, but that the emphasis upon paramedic safety, I think, is one of the biggest concerns I have. And you look at, you take a commercial airliner, or you get in a helicopter with Orange, and you can't get in there without a helmet, and you have everything strapped down, everything's seat belted, and yet there's not a lot of airline crashes, thankfully, and not a lot of helicopter crashes, thankfully. And I really don't think, unfortunately, that the seat belt and the helmet's going to help you if you're at 5,000 feet and take a nosedive. But yet one of the most dangerous vehicles out there is an ambulance for every mile driven. And our paramedics in the back, fully unrestrained, trying to do CPR, providing crappy CPR, we know, because it's impossible to do in a car that's going 120 kilometers an hour down Richmond Street. And then you have these devices that are capable of providing good CPR. So from a paramedic safety point of view, there is compelling evidence for this.
The other concern about industry-sponsored studies, and this we've known this for years from drug companies, is that the potential for having negative studies buried and never come to light. And you never know how many there are that have occurred, because no one but the industry and potentially the study, the principal investigator, who was being paid by the industry, would never know that the study was buried if it was negative. So I'm not sure if the same applies for these devices. Maybe it does, maybe it doesn't. I don't know if you've heard anything or read anything about that, Kate, but that's another concern with these industry-sponsored studies.
And I asked Shelley about that a little bit, like there are negative studies happening, Shirley, and she said, well, now that, it's mandatory that you register with clinicaltrials.gov, like for all of us, we might never know. But I sat down with Shelley and she's like, oh, well, you can totally find these buried studies. You just go on clinicaltrials.gov and you can look it up and it should all be there. So I think if you have the right people who know how to find things, it's not easy, but potentially now legislation is such that it should be more accessible when the studies are coming out with negative results, that at least there's a paper trail that they existed somewhere once, because I had that concern as well. So she seemed to think, at least with clinicaltrials.gov and the fact that people have to register, these device trials have to register as well as clinical trials, that should help a little bit, but it maybe helps more for people with a ClinEpi background than for us who are kind of getting what shows up in the journals.
So Mike, why don't you guys, there's been some studies too that show that, lights and sirens mean nothing. That means about 2 minutes, and most of these crashes occur, when there's lights and sirens. So why aren't we pushing to not have that, lights and sirens?
I completely agree with you. In fact, one of those studies was my own study that I did during resident research day, where I drove every code 4 that the ambulance did for a month at the same time of day the next week, and it showed that really during peak traffic time we save an average of about 2 minutes in urban transfers, and that was not the clinically what clinicians think is clinically significant for most patient encounters that are traveling code 4.
Kind of two questions. Do the paramedics ever stop on transport to perform any acts? Is it just for intubation that they stop for? Or there's nothing that guides them to stop the transportation?
They should only stop if someone arrests en route.
If
so someone has a pulse and loses that pulse en route, they stop
to run
a code. Other than that, they should never stop. So they shouldn't be leapfrogging cars.
Okay. And then the other question is, what guides the change? You could argue you should never transport a cardiac arrest patient. Right. So is it because we don't have advanced paramedics kind of running the majority of our codes, and we can't let our primary paramedics do it? Or?
Exactly, that's exactly it. Advanced care paramedics theoretically can provide the same quality of care, same care in most situations on scene for most cardiac arrests that we can provide in the emergency department. And that's why they have the ability to call and ask for pronouncement without a specific list of indications. Whereas the primary care paramedics, thankfully, as of just this past year, can call for medical termination resuscitation for the futile cardiac arrest. There are places where they only transport people with a pulse.
Well, it seems to make sense, right?
Yeah.
It's not that
but
we're providing any extra things in someone without a pulse.
10 years of resistance, when there was good evidence for medical termination resuscitation, to allow that in the completely futile, because there was 3 or 4 survivors in the trial that was done in Toronto and Owen Sound with that list of, never non-witnessed arrest and never shocked and never had a pulse kind of thing. So imagine the resistance now to well, you're going to miss 10 of 1,000 people or 10 of 5,000 people if you don't transport anybody.
Right. I think, Kate, it gets down to, I mean, it's so confusing and you get slicing and dicing, but the bottom line is, like you said, there is very, very few things in pre-hospital care that's been shown to make any difference at all. Any, none. You listed 3, and I think that's about it.
Pre-hospital.
So then, okay, we won't go there. We need a job. But but then to start slicing and dicing, early CPR has been shown to make it. Now to be slicing and dicing how you do that CPR. I mean, there's been 4,000 manufacturer-sponsored studies, which are slicing and dicing every which way to get a positive. And this one it just doesn't pass a sniff test. That doesn't make sense at all. There's been 800 devices. There's no way this is gonna bear out. But like you've seen, Mike's coming under pressure to buy those things, and it's just totally.
But that's the take-home message, Derek, shouldn't be that the devices don't work. It should be that all of us who resuscitate cardiac arrest should be doing more compressions.
Yes.
That's that there is evidence that more compression saves lives with good neurologic outcome.
Yeah, but the biggest pre-hospital study, I think the one out of Arizona, was just a huge public education, right?
Yeah.
Just do something, and that had the biggest results of anything, not putting some device in, just get down there and just do something, just push on the chest.
But
early and
the
hard.
people in this room are all emergency department care providers, and we don't do compressions in the department. Like, we don't yell at whoever's supposed to do compressions to do compressions and keep doing it.
Yeah.
We stand back and look at the monitor for a minute. Like, I've seen it all the
Well,
time.
we've all seen paramedics come into the, we're going
Like
like
the one
this,
hand like this. So that to me is the take-home message. Is we need to do more compressions. And there are social media campaigns. If you search YouTube right now for CPR, you'll see the American one, which has lots of TNA, pardon the impression, in it, and the European one that's got some good gangster jokes in it, kind of thing, and it's very cultural. There are 2-minute videos on how to do compression on CPR, and that is where, in my mind, where we should be going. But it's more compressions, more compressions, more compressions. Whether you do it with an AutoPulse or a plunger or your fist, doesn't matter. It's just do more compressions.
Just 2 historical comments. The 2 guys who invented CPR, Jude and Kuenhoven in 1960, actually described chest compression only CPR. And it was only when they sat down with a fellow by the name of Peter Safar, who was an anesthesiologist, that he said, oh, this sounds really great. Had some survivors, whatever, but breathing has got to be good for people, so you should combine it with ventilation. So here we are 50 years later, and we're getting very close to a point of saying, maybe the ventilation isn't all that important, and certainly the chest compressions we know are really important. And the other historical comment is that when I was a resident, a long time ago, in Baltimore, they were doing research on vest CPR, which is extremely similar to this AutoPulse. And again, it was hailed then in the 1980s as being, the thing. And there have been, there's been thumper out there for a long time, vest compression, decompression, compression, decompression, which we participated in the original trial on. None of these things have ultimately, there was abdominal counterpulsation CPR as well. None of them have panned out in the long term. So you really got to be kind of suspicious about the influence that industry is having in some of these studies.
I just have one quick question. It's just listening to some of the new literature on EM crit, and this is in the idea of just pushing the damn chest, which is what we should be doing. And I think it's the same people who made the plunger are starting to talk about stagger start CPR to avoid ischemic injury during the beginning, or oxidative injury during the return of spontaneous circulation. Have any of you looked at that data coming out? Because it sounds completely ridiculous to me, but they're saying 30 seconds on, 30 seconds off, and it's coming out by the same guys who are making this plunger thing.
No, that's not reached my radar in terms of prime time yet. That kind of, it just strikes me that the more, I echo the comments of everyone else, I just think the literature prevailing has been more compressions is better. And yet again, it's a pendulum. But I think that the AHA guidelines stopped short of continuous compressions because of 2 of the papers that looked at continuous compressions came out after the authorship of the AHA guidelines came out. So therefore, they're a bit watered down with their recommendations. I wouldn't be surprised if the next iteration of the AHA guidelines come out with compression-only CPR as their main recommendation, which would be very different than suggesting a staggered start one. And most of these trials are like thousands and thousands of patients, so I'm not sure if that's reached prime time yet.
It's great.
Well done, Kate. Thank you very much.